Hello, everyone. Thank you for joining our webinar, Straight Talk about Bone Health After Breast Cancer. I have the wonderful Dr. Graeff-Armas with us. She is a board-certified physician at Nebraska Medicine, and she's an associate professor of internal medicine at UNMC. She is born and raised in Nebraska, and another cool thing is that she went to all of her school here in Nebraska at Creighton. She had a fellowship in diabetes and endocrinology, and she also had a research fellowship that was supported by the National Institutes of Health. She joined UNMC 3 years ago with a focus on osteoporosis and metabolic bone disease, and runs the secondary fracture prevention program in collaboration with orthopedics. She has a research interest in calcium and vitamin D nutrition. In this spring, graduated with her PhD in medical nutrition with a focus on nutrition in post-fracture patients. She spends her free time driving her 3 kids to various activities, as well as volunteering her time tonight to help us learn a little bit more about bone health. So I will let her take it from here. Remember to feel free to ask questions down at the bottom of the screen, and after her presentation, we will go ahead and answer those. So here we go.
Okay, so I'm excited to talk to you about bone and breast cancer tonight. So this is a little bit of a different field for me. I usually spend my time meeting with 75 to 95-year-old patients after they've broken a hip. So I get really excited when I can talk about prevention, because I would love to see people on the other side before they get to the hospital with their hip fracture. So I'm an endocrinologist by trade, so I'm kind of coming at this from the endocrinologist perspective. I learned quite a bit just kind of reviewing where breast cancer treatment is, but I will tell you my last oncology rotation was when I was a resident 15 years ago, so lots of things have changed. The bone side of things, you know, there's lots of things that affect bone. We'll talk about that. And the nutrition side of things, there's new information on that. But if there's any specific oncology questions, that is not my expertise, so I will tell you that. But if you have general osteoporosis, vitamin D, calcium, protein questions, that is where I like to live. So I start with this slide. I always show this to my fellows and residents. Shows your nice strong bone on the left side and then your osteoporotic bone on the right side, and you can see much thinner bone, and it doesn't look like it's going to hold up in a stiff wind. And so that's what we want to prevent. And how do I scroll down with slides?
Is the arrow?
Oh, just click. Okay. Okay, so I'm going to come at this kind of from the endocrine side of things. So a good guide that I follow is the American Association of Clinical Endocrinology when they talk about treating postmenopausal osteoporosis. And then for this specific audience, I really looked at the Journal of Bone Oncology, where they talk a lot about using aromatase inhibitors and those effects on bone and how that changes our management. So I'd like to start with this. This kind of shows us what happens during lifespan with bone. And you can see, and we'll focus mostly on women obviously here, but you know, women gain bone through their young years. Teenage years are a high growth velocity for bone, kind of the time when no one really cares if they drink milk or exercise and do all those good things. That's when you really add onto your bone mass and reach peak bone mass. Peak bone mass is kind of reached early 20s, and a lot of that's determined by genetics. You know, obviously if there's serious illnesses or medications that people need to be on when they're young, that's going to affect peak bone mass. But people in the population are generally healthy, generally doing well. That peak bone mass is really about 60 to 80% genetic. So you can blame your mother for that one. Maybe your father, but I always say mother, since they seem to always get the blame for these kind of things. Then the bone mass is really maintained throughout those next 20 to 30 years until menopause. And this kind of becomes important in breast cancer, because we are talking about menopause and either being put into menopause or starting menopause during that time. And there's a pretty drastic reduction in bone mass at the time of menopause, even under just normal circumstances, normal menopause, just losing estrogen, there's about a 10% loss of bone mass. No explanation on why that would be helpful in the long run, but that's very typical that we see that in almost everyone. And then after that, the bone, this doesn't show it quite as a straight line, but you usually maintain bone mass, you know, once you have that bone loss through people in their 60s. And then there's kind of a gradual loss as people get older. And then one of the things we'll talk a lot about estrogen in this talk. Estrogen is kind of our focus with breast cancer. And we just, you know, said losing estrogen is bad for bone. And we're really focusing on if you have breast cancer cell that's estrogen receptor positive or it's responding to estrogen, obviously you want it to, you know, not respond to estrogen and decrease the growth of those cells. So this is just, you know, an example of with estrogen, receptor positive breast cancer cells are going to increase, and without estrogen you're going to minimize growth, and that's really the goal with breast cancer, and we have to take that into account when we're looking at bones. But there's other things that can affect bone. There's a huge list of things that can, and so we talk about estrogen. A lot of times people are put into menopause either surgically or through chemotherapy at the time of their breast cancer treatment. And then there's just even blocking estrogen production with aromatase inhibitors. So there's very little estrogen for those cells to respond to. But then there's kind of practical things, just things like nutrition. You know, people might have a weight loss during that time or a lack of appetite, not able to get in good sources of protein if that's just not going down well and not tasting good. And then just generally calcium and vitamin D deficiency can take a toll on bone. And then steroids are another thing, you know, it's helpful to help with nausea during chemotherapy, but that also has a direct effect on bone. So all these things we kind of have to take into account when we're treating patients who are have breast cancer. Ooh, we're getting an echo. And then also, you know, keep their bones health in mind. So just wanted to show you this slide. So we have cells that form bone, such as osteoblasts, and then we have cells that eat out bone and resorb bone called osteoclasts. And the blasts are very sensitive to estrogen, and estrogen kind of keeps those cells healthy. And of course, we're trying to block that estrogen effect. So we're having this direct effect on bone formation. Some of the medications that people use to block estrogen, probably the most important one now that we're seeing are aromatase inhibitors, which block the conversion to estrogen, and I've listed 3 of those here. And then when I was a resident, which has been many years ago, longer ago than I'd like to care to tell you, tamoxifen was a big treatment for breast cancer at that time. It's still used. That one actually helps bone. It's actually stimulates estrogen receptors on bone, which is a good thing, and inhibits the estrogen receptors on breast. So that's still used, and we'll talk a little bit about its kind of cousin, raloxifene, later in the talk. And then if someone's premenopausal, a lot of times rather than take out their ovaries and put them into permanent menopause, they'll suppress ovarian function with other medications. And again, kind of the downstream effect of that is just decreasing estrogen. So we all really have the same types of long-term effects on bone with those medications. So what we worry about the effects on bone is not so much that the bone mass is low. I don't get too excited about people's numbers on the bone on their DEXA scans, and we'll talk about that. But what we really worry about is that they break bones and that they fracture. And we know women with breast cancer have a higher rate of fracture than the general population. And about 1 in 5 women, or 20% on aromatase inhibitors, will have a fracture. So it's really foremost in our mind to be very aware of this going into treatment. So this comes from the guidelines on aromatase inhibitors, on just who to really look for fracture risk. And the people that'll be the highest risk would be in age, greater than 65, and that's going to be true across the board, whether somebody has breast cancer or doesn't. People, age increases fracture risk just simply because older bone is just more fragile. If someone's had a history of fragility fractures, so we define that as they've had a fall and they've just been, walking along or slipping, they slip on ice or something like that. If they've had that kind of fracture before, those people are at higher risk. And we know that just because the bone's weaker, and so they could have another fracture. Of course, we talked about steroids, history of steroids for other things other than, the breast cancer treatment would be a risk factor. And then we'll talk a little more about DEXA scan T-scores, but they said a T-score less than -1.5 is someone you should really be looking at their fracture risk. And then there's kind of some general things, things like low body weight, smoking, family history of hip fracture, and then they put women on aromatase inhibitors on this list as well. So I found this lovely slide. It's probably about 30 years old, shows you what a DEXA scan looks like. The DEXA scans look about the same. They're basically a table here with the computer that prints out your results. I think it's about 30 years old because I think the hairstyle looks about 30 years old on this lady. But the technology really hasn't changed. We get the same information that we did 30 years ago. And this is the two pictures that we get. We get spine bone mass, so the kind of the lower spine. We look at those vertebrae, and then we get the hip. And some places measure one hip, some people measure both hips. It doesn't really matter. Usually your hips are pretty much the same on both sides. And you get numbers called T-scores. I mean, you get lots of numbers, but really what we're going to focus on is the T-score. That's probably the most meaningful number. For the spine, the femoral neck, which is this small portion here, which if you hear about people breaking a hip, a lot of times that's where they're breaking. And then we get the total hip, which is that whole area. So here's T-scores. So T-scores, basically what they mean is they're comparing a person to a young, about 30, 35-year-old person. So they're at their peak bone mass. That's what's called a T-score. Normal bone density is above -1, so -1 and anything above that up to +1 and then beyond is normal. And then osteoporosis classically is defined as less than -2.5. In breast cancer, we start worrying about it a little bit sooner just because of all the other risk factors. So rather than wait until someone's at this -2.5 number, we're looking at it more at -2 or -1.5 just because you've got all those other factors that could lead to fracture. So this is what they recommend for a reasonable workup. Most people that are actively seeing bone patients will have all these numbers, but usually, as part of your just general chemistry, you'll get a calcium. Vitamin D measurement's important just to know that you're having enough vitamin D to absorb that calcium. I always measure phosphorus, and they recommend measuring that. That doesn't come on just your usual lab tests. I pick up a fair number of kind of some rare bone diseases with that. Most people have a thyroid function. You always get a kidney function test on your regular blood work as well. I tend to measure bone turnover markers. Those kind of give me a hint about how much those osteoblasts and osteoclasts are working, and I find those helpful, but I measure them probably 10 times a day, so I kind of have a feel for where those will end up. And then just, your red count and your white cell count and those kind of things are real common to measure. And then this guideline recommended measuring a protein electrophoresis, kind of looking for other issues with the blood that could cause problems with bone. So that's kind of the common sense things. We'll talk more about calcium and vitamin D, and I could talk for an hour about each of those subjects, so I will not bore you with that. Exercise is important. People always hear about weight-bearing exercises and think they need to be, at the gym pumping, heavy weights, and it really means just walking, bearing your own body weight. And, any kind of exercise is helpful for bone. Just moving the muscles against the bone is helpful. So if people, have a lot of pain and they can only swim, swimming is better than doing nothing. So I encourage you to do whatever you can for exercise. Minimizing falls. most of my patients don't just fracture on their own. They usually hit the ground. And so if you can stop falling down or get some padding so you don't hit so hard, that's helpful. And then all the things your mother told you, stop smoking, stop drinking, those kind of things are helpful for bone as well. So I'll start with calcium. Calcium's interesting. So when I started in the field probably 15 years ago or so, calcium was just kind of I would say a no-brainer. Everybody knew you should drink milk for your bones. Calcium was good for your bones. And it really wasn't controversial. We knew a lot about it. And about 5 years ago or so, there's been a lot more literature on calcium and heart disease. And I think that's caused a lot of confusion in the field. If you go back and look at a lot of those papers, they're all coming from one source. And I don't know what this guy has out for calcium, but he's caused a lot of osteoporosis patients to go off their calcium supplements. What we do know about calcium, it's kind of like everything else in nutrition. There's moderation in everything. So I always recommend to my patients right around 1,200 milligrams of calcium, but that includes what they're getting from food. So a lot of people are getting probably half of what they need from their food. They get a little milk on their cereal. They're eating some cheese. There's a lot of calcium because we eat a lot of bread and cereal. There's a lot of calcium in bread and cereal that we don't really think of being a calcium source, but in the U.S., it's our second source of calcium is bread and cereal. So I always emphasize looking at nutrition labels, seeing if you're getting enough calcium from the diet, and if you're kind of shy of that, just taking a supplement that's just that, just a simple supplement. The other thing about calcium is all of the medications that we use for osteoporosis treatment, they were all tested with calcium as part of the regimen. So during all those trials, they gave all those patients calcium. So we don't know that those drugs will work as well if they don't have calcium as part of their regimen. So if you're looking at calcium on a nutrition facts label, this is from a cup of milk, it appears to be. Calcium will always be down there kind of at the bottom, kind of seems like it's not important, but that's where they put all the good stuff. And they always report it as a percentage. So they'll report it like this case is 30%. You just add a 0 and that will equal how many milligrams are in that serving. And so most people are getting, 600 milligrams or so from their diet in general, and then they just need to add a supplement to that. And I usually recommend a couple of different ones. I try to steer toward chewable ones. Some of my patients don't mind taking a big horse pill every day, but most of my patients would prefer something that's chewable and easy to swallow. So I usually use Tums because those are easy. Everybody has them at their house for their heartburn, or like a Viactive calcium chew or a Tums calcium chew or something that's chewable and easy to take. And usually they just need to take that once a day if they're getting a reasonable amount of calcium from food. And so those supplements should be taken with food. So usually once a day with breakfast or dinner, they can add that calcium in. And then vitamin D has been very popular for the past 10 years. Everybody's on vitamin D. I try to hit a blood level of about 40 nanograms. The recommendations say from 30 to 50. 40 seems kind of middle of the road. To hit that, most of my patients only require about 1,000 to 2,000 international units of vitamin D3 every day. Lots of people are taking a lot more than that. You can take a good amount of vitamin D. I don't know that it's absolutely necessary. So I just try to kind of hit that 40 nanograms. So, and those tend to be pretty easy. If you have a patient who doesn't want to take more pills, I'll use vitamin D drops, and that's really helpful. And that's kind of how I sneak it into my kids' milk every day. Then I talk a lot to my patients about protein, because protein is really key, especially my patients who are elderly, who really have a hard time. Maybe they've had tooth loss, maybe they have lost their appetite for protein-rich foods. We know that bone's made up of protein, and so if you don't have enough protein, you tend to lose bone. And this is patients who are 75 and above, and they followed their bone mass for 4 years, and they saw that those who were getting the least amount of protein lost the most amount of bone, and those who were getting the most amount of protein gained the most amount, or lost the least amount of bone, I should say. They all kind of lost some, but some less than others. So I really try to emphasize that in my patients. I tend to use a lot of like Ensure and Boost and things if they're not getting it from just, you know, meat and chicken and fish and things like that. So that kind of leads me up to kind of all the preliminary stuff before we get to medical therapy. The algorithm, I think this is a good algorithm to follow. This is specific for people on aromatase inhibitors, but it's basically in a patient with breast cancer who's receiving aromatase inhibitors and kind of where to look. First, you'd start with a DEXA scan because you'd want to know how much bone mass, and then depending on the DEXA scan T-scores would kind of push you down one of these pathways. So if they had pretty good bone mass and no other risk factors, you know, we talked about age and history of fracture, family history of fracture, steroids. If they didn't have any of those things and their bone mass T-score was greater than -2, they would recommend exercise, taking calcium and vitamin D, kind of doing what everyone in the population should be doing for their bone, and then looking at the bone mass every year and making sure that they're maintaining that bone mass. Then down here, this pathway is patients with a T-score less than -2.0. And so those patients are still in the osteopenic range according to kind of our classic definition. They're kind of in that yellow, middle of that yellow range. And those patients, they recommended starting on bisphosphonates. So that would be, could be oral bisphosphonates, and we'll kind of talk about those in specifics, but could be the IV form. And plus the calcium and vitamin D. None of our drugs replace the calcium and vitamin D. Those are kind of baseline for everybody. And then again, monitoring bone mass, usually every 1 to 2 years. And then there's the patients who are kind of in the middle here, who don't have real low bone mass. So they've got a T-score less than -1.5, but probably higher than -2, but they have other risk factors. So all of those risk factors that we talked about, their age, low body weight, hip fracture, that they've had a family history or personal history of fractures, and then steroids and smoking. And I thought this was interesting. They said even a history of smoking kind of put them in this category, which I haven't typically used a history of smoking. I've usually used current smoking. So here's all the medications we have for treatment options for osteoporosis. There's a couple that wouldn't be used in active breast cancer patients. Obviously, medications with estrogen, you're trying to get rid of the estrogen, so that would be out. And then there's some medications that are stimulating bone, and those we wouldn't usually use until after kind of the breast cancer's been completely treated. So that leaves us with, let's see, I think these all show up on the slides. The main one would be bisphosphonates. So there's some oral ones. So you've probably heard of Fosamax being kind of our oldest one. That's been around for about 20 years. And then there's Residronate, which is Actonel, or Abandonate, which is Boniva. Those are all oral, and those are real reasonable. I use a lot of oral in my patients, but with all the other medications and things going on, a lot of times doctors will just choose to do an IV form, which is very reasonable. And that kind of depends on the doctor. Some of those, I usually use them once a year, but some doctors will use those every 6 months, and even more if there's any metastases of the breast cancer to the bone. And that has the most data because it's been around the longest time. Then there's these estrogen receptor modulators. So tamoxifen, which I spelled wrong, is the one that's typically used for breast cancer treatment after kind of 5 years after breast cancer treatment. Raloxifene is kind of the sister drug to that, and that's the one I use. It's a little bit different. We'll talk about when that's appropriate to use. And then our newest one is denosumab or Prolia injections, which is getting more popular because it's convenient. It doesn't have as much data as the zoledronic acid. So a little bit about the drugs. So the orals, work real well. They're a little bit picky, and that's where we kind of run into just difficulty in taking them, and they don't absorb that great, and so they have to be taken fasting. You have to wait for your coffee, which would be my downfall with this one. You have to wait 30 to 60 minutes before coffee, other medications, or food, and so that can kind of, even if it's once a week or once a month, sometimes that's just difficult to remember, or just hard to get it separated from if there's a lot of other medications that the patient's using. And then if a patient has any problems with their esophagus, it can be a little irritating to the esophagus, so it wouldn't be used in that case. And then you end up using an IV form, which people do pretty well with that one. And then we talked a little bit about these selective estrogen receptor modulators. So tamoxifen is the one used after breast cancer. Raloxifene actually is used usually before breast cancer. It has a indication to prevent breast cancer, which is kind of fascinating. It acts like estrogen on the bone, but as an anti-estrogen on the breast. So that one I tend to use in patients that are younger and maybe have some worry about breast cancer in their family, or they've had maybe some diagnoses that make them worry that they might develop breast cancer at some time in the future. Sometimes that's a helpful drug to use. And then our latest drug, this has been out for probably 8 to 10 years, is denosumab. And so this is given as just like a flu shot. You just get an injection every 6 months, which makes it convenient from that standpoint. What it does, so these are my bone resorbing. So these are the big cells that take out bone and get rid of bone. This drug actually stops those from even forming. So they're just not even there. So it's pretty helpful as far as that goes, as far as not losing bone. However, it is an antibody, so when that 6 months is done, it's just gone. And so we're seeing more data coming out that you can't just stop it. You have to go do something else afterwards, so you can actually have more those cells come back and they take away more bone, and people are having some fractures. So it's kind of a little bit newer information with the Prolia. I think it's a good drug. You just have to know when you're going to stop it, when you're going to end it, what you're going to do next, and have a game plan for that. The other thing about it is you have to have your vitamin D and calcium deficiency fixed. So I have a lot of patients who really aren't eating well. They're not getting their calcium, their protein, they're really vitamin D deficient. I'm really careful about putting those patients on some of these medications because they're relying on their bones. Bones are great as a source for calcium. So you can just pull whatever calcium needs you have from your bones because they hold a lot of calcium. But if you shut the skeleton down with your drug, and you don't have any source from your diet, you can get into some trouble and the blood levels of calcium can go down. So I just always caution people to make sure they're getting their calcium and their vitamin D before starting those medications. And then I have other slides, but I thought it would be more interesting if we had more questions, just because since that's going to be most interest to you. And then I see patients with osteoporosis at UNMC and at Bellevue and in orthopedics. So, yeah. Oh, it looks like we have lots of questions. So
a lot of questions.
Okay.
So I just want to reiterate, there is a Q&A little button down at the bottom of your screen, whether you're using your desktop or your smartphone. Go ahead and click that and type any question that you would like, and we will try and get it answered in our time allotted. So first question I'm going to ask is, having breast cancer in your mid-30s, should you still worry about bone health after?
Yeah, so so this is going to be kind of a general answer. So I'm assuming if someone's in their 30s that they've been having normal periods up until the time of the breast cancer. And it kind of depends. Sometimes doctors will kind of shut off that estrogen temporarily. That'll have an effect on bone. And so that's a time to make sure you know kind of where you're at bone-wise. And then if you need something temporarily to kind of maintain your bone while you're being treated, that's very reasonable. really isn't dependent on age as much as on what's happening with the estrogen.
Should I have a baseline scan or test prior to treatment?
I would say yes. I think the guidelines are pretty clear. It's nice to know what you're kind of going in with. Based on what happens at menopause, you can lose about 10% of your bone mass. And so I feel, I usually see people, if I see people before menopause or right at menopause, I like to know, are we going in here with a T-score of 1? Are we going in here at T-score minus 2.5? Because it's going to change what I do. If you have lots of bone and you could lose a little bit and wouldn't really notice, that might change what you do for treatment. And if you have really low bone mass already to start out with, just because of genetics, you might want to be more proactive and get on some kind of medication.
This is a good one.
Yeah.
I have been diagnosed with osteopenia. Will I get osteoporosis, particularly since I can't take a hormone replacement?
So that depends on a lot of things. It depends on age. My goal in patients is that they maintain their bone mass. So if you're in osteopenia, it means you're between -1 and -2.5. That's kind of a big range to be in. If you're following bone mass, you want to make sure it's maintaining. I have lots of patients who sit in osteopenic bone range for years, so that it depends a lot on what else is going on. If you're starting other medications, or you kind of completed medications and you're kind of at the end, I would just continue to follow it pretty closely.
How often should I be tested?
Well, I usually test patients if there aren't a lot of health problems every couple of years. But if you're on treatment for the breast cancer, they're recommending every year. And because there can be good, pretty dramatic changes in that time period. So once a year seems reasonable.
You already answered that one. What can I expect from bone loss treatment?
So the goal is really to maintain bone mass. I know there's ads out there that say you gain bone. You don't really tend to gain bone. The goal is really to maintain where you're at, and stop that bone loss. And so if you're staying in that kind of the same range that you were at baseline, that's really the goal. I think patients get disappointed if their numbers don't go up, and it's okay if their numbers don't go up. We just don't want them sliding down further and further down.
At what age should I be tested for bone loss?
So in general, we recommend people get tested at age 65. If they have all these risk factors, kind of the ones we've talked about, family history and things, it's better to have that done earlier. I personally like to have it when people go into menopause, just because of the things we talked about, that you lose bone at the time of menopause when you don't have estrogen. So it's nice to know where you're starting out from.
Okay. I'm going to try and pronounce this.
Okay.
I have Hashimoto's.
Mm-hmm.
For years, PCP kept TSH low, out of range, while T3 and T4 were WNL, treated based on symptoms. Does this increase risk for osteoporosis?
So it does if you've been, so that would be where you've been hyperthyroid for a while, just because the thyroid medication's been over replaced. So that can, over time, kind of wear away at the bones. So the goal would be really to get that TSH and get that thyroid function back to where it's just right in the middle of the normal range. I like the TSH between 1 and 2. So kind of the long answer is, yeah, over many, many years of being hyperthyroid, that can be hard on bones. So I would try to get on a good dose that's reasonable now.
You guys are asking great questions. Thanks. I'm almost 58. Should I have a baseline DEXA?
If you have risk factors, family history, if you had breast cancer, that would be a risk factor right there. If you've broken a bone, if you have family history of broken bones, low body weight, steroids, those kind of things, then you'd want to get one right away. In their 50s, I always find it helpful just so people kind of know what to prepare for.
I have osteoporosis and I'm taking Fosamax and am vegetarian. How much protein should I get each day?
So the recommended dietary allowance is 46 grams for women. It's hard to do as a vegetarian. I mean, I'm not a huge meat eater, but your most concentrated form of proteins in meat and chicken and fish and things like that. So it's hard. You can get protein, but you really have to pay attention. Things like Greek yogurt or beans. Sometimes you just run into a volume issue. It's hard to eat that much food to get that much protein. So you just have to pay more attention to it if you're a vegetarian.
What treatment did I have that made me at a higher risk? Does that make sense? Or is there a specific
treatment that could make you at higher risk for breast cancer in general? Well, there's lots of things that can affect bone. We talked about the aromatase inhibitors. Those medications decrease estrogen. So anything that interferes with estrogen, whether it's for breast cancer or if it's for something else, that can cause bone loss. What I see in my practice is steroids being kind of the most common thing. People are on chronic steroids, and that can affect bone. So hopefully that answered that question.
I'm a 2-year survivor on letrozole. I have a lot of lower leg discomfort. Is that a normal side effect?
I don't use that drug. I don't prescribe that drug, so I don't know that I can answer that.
Okay. We just went through all those questions you asked. I don't know if did I ask about symptoms?
Symptoms of bone loss. So symptoms of bone loss, this is kind of one of those questions. Most people aren't going to have symptoms. The number one reason that people know they have osteoporosis is if they break a bone. And so that's the importance of getting a scan, like a DEXA scan ahead of time, because that's going to be your only way of knowing. You can look at your family and say, well, my mother, lost a lot of height when she got older and she fell down and broke her hip. So maybe I'm at higher risk if I inherited her bone mass. But there's not symptoms there you would feel anything. It's kind of one of those silent things.
Does radiation affect bone loss?
So radiation would affect bone. They try to focus it directly at the cancer. Of course, they're going to hit some bone around it. It won't cause generalized bone loss. I can't think, there's very few times where you'd have radiation to your whole entire body because they really try to focus it towards that. And it can be, hard on the bone that gets hit, but it's not going to be generalized. It does make a difference in what medications we can use. The ones we talked about are safe with patients who've had radiation, but there's some other bone drugs that I use that are contraindicated in people who've had radiation.
Okay, that was all the questions. That was really good.
I talked too fast.
Well, thank you guys so much for asking all those questions. Yeah. If you have any more, try and sneak them in real quick. Let me just go ahead and make sure. Oh, we got another one. Yay. Okay, hold on. I'm 50 years old, 2-year survivor on tamoxifen, and have been given options for BSO because of my CYP2D6.
Okay.
Came back.
I do not know what those numbers mean, but that's okay.
Heterozygous with one null allele. Which is better on the bones, Lupron or BSO? Oncologist says ovarian suppression would decrease recurrence by 4%. Should I try my chances and stay on tamoxifen?
So, I look at the question again.
Yes,
there's a lot of details in this question. There's a lot we can do for bone. And so I just had this conversation with one of my patients. She was asking, well, should I do this for my breast cancer or this? And honestly, it's going to come out what's better for your breast cancer and your survival. We can do a lot of things with bone, to maintain bone. So I would probably answer that question. I mean, tamoxifen is good for bone, but that might not be ultimately the best thing for your breast cancer treatment. So I would go focus on the breast cancer treatment and then follow up with what's needed to kind of follow up with bone, if that makes any sense.
Let's just, oh, we got some more. Right here.
Oh, yeah. When should you get your DEXA scan if you're on an aromatase inhibitor? So they recommend it if you've been on it or if you're starting an aromatase inhibitor to get a baseline DEXA scan. So that would be my recommendation. And then the next question is, too much calcium bad? So this is an interesting one because we don't have great data on too much calcium. Now, I think about 12 to 1,500 milligrams a day is real reasonable. It does look like if people are really pushing that high, like 2,000 milligrams or 3,000 milligrams, that could lead to some cardiac calcifications. So you're getting some calcium just sitting on your heart, which probably isn't good for you. So I try to recommend, keep it in that 12 to 1,500. If you're getting, a decent amount from food, you might back down a little bit on supplements to hit that mark. Because I've done that myself. I did a nice little study on my patients who just fractured, and I realized we were really pushing them with their calcium because they just broke a bone. So we were, giving them extra calcium. They were drinking all their milk. They were taking all these supplements. Maybe they were taking a boost or an Ensure, and they were really pushing that 2,000 to 3,000 mark. So I realized people are getting a little bit more calcium than I count, and so a lot of times they just need to add everything up and just try to hit that 12 to 1,500 mark and not push it over 2,000, because more in calcium isn't necessarily better. It's not necessary. It's not going to your bone. The bone can probably only take up so much, and then it kind of stops taking it up. Will most insurance pay for a vitamin D level? This is a good question. I think it depends on what indication. If it's just screening, I don't know that they necessarily do that. If you have osteoporosis or you have osteopenia, then they can bill it under part of that diagnosis. But if it's just a screening vitamin D, that might not get paid for. Same question. What seems to be the most helpful to maintain or improve bone health after being diagnosed with osteoporosis? As far as the medications, they all work pretty much the same. They all have different things that are good or bad about all of them. What I tend to base my treatment decisions on is what's tolerated, kind of what the patient's goals are, what the side effects are, and what the cost is. And that's ultimately what it kind of comes down to, because they all do about the same thing. And a lot of times patients are on all the different medications at different times. We just switch them from one to another over, a 20-year period. They're on lots of different medications. I've been on 50,000 IUs of vitamin D weekly for years. My vitamin D level is at 50. Is it a problem to stay on the supplement long term? No. So vitamin D is something we all need. You're getting a good amount of vitamin D2 is probably what that is, since it's prescription, and 50 nanograms is a reasonable dose to maintain. There's not any reason to stop it. And I think, did we reach all the end? I think we reached all the end of the questions. So
thank you guys.
Yeah,
for
thank
so many
you.
questions.
We had lots of good questions.
Yes. And if you guys think of any questions later on, either tonight or tomorrow or later in the week, go ahead and contact. All of her contact information is right here, and I'm sure she'd be happy to answer anything. And we'd like to say thank you so much for joining us and giving us all this wonderful information. I'm sure everyone enjoyed it, because I know I did. I learned a lot that I had learned before. I wanted to let you guys know that our next Straight Talk webinar is December 4th, and it is over fear of reoccurrence. So how you guys get registered for that is the same way that you did for this one. Just hop on the website, projectpink.org, and go to Straight Talk and register, and that's how you do it. So thank you guys. Have a good night, and see you later.